So hello guys, hopefully all of you are doing well, bacho. Now, let's talk about the important points regarding anatomy. Okay. So now the first one that we are able to see over here, beta, this image has come earlier in the examination also. So please be aware of this. So here you are having a lesion or a damage in the spinal cord, beta. We know there are three columns in the spinal cord. There is an anterior column, there is a lateral column, and there is a dorsal column, beta. Okay. The anterior column, which is there, it is going to carry the fibers which are responsible for crude touch and pressure, beta. Okay. Whereas the lateral column, ओके जब लात पड़ती है तो क्या होता है, जब लात पड़ती है तो दर्द होता है और गुस्सा आता है और टेम्परेचर बढ़ता है. सो डेफिनेटली you have to remember that the lateral column is going to carry the fibers of pain and temperature, right? It is going to carry the fibers of pain and temperature, whereas the dorsal column, which is there, it is going to carry four functions. Which is the dorsal column, it is going to carry four important functions. And what are those functions or what are those sensations? First, it is going to carry definitely the fine touch. Crude touch was carried by anterior column. Fine touch is carried by the dorsal or the posterior column. Okay. Whereas it also carries the vibration sense. It carries the vibration sense. Apart from that, it carries the joint position, also known as proprioception. Joint position of proprioception, and lastly, stereognosis. Stereognosis, right? So these four functions are carried by the dorsal column. So these are the sensations which are carried by the various columns of the spinal cord or various fibers in these columns. Definitely the anterior spinothalamic fibers, the lateral spinothalamic fibers, and the dorsal fibers known as known as the sorry, fasciculus cuneatus and fasciculus gracilis, which is okay. So these fibers are going to carry these respective functions. Now, if I say there is damage to the spinal cord, beta, this condition is known as hemisection of the spinal cord, also known as the Brown-Sequard syndrome. Now, in this condition known as the Brown-Sequard syndrome or hemisection of the spinal cord, which is what is going to happen over here? The spinal cord is going to get damaged, right? And as the spinal cord will get damaged, beta, definitely, which columns of the spinal cord will be affected? Mainly the lateral and the dorsal column is going to be affected. Yes, hemisection, that means half of the spinal cord is damaged. So only the lateral and the dorsal column are damaged, but the anterior column are saved in a case of Brown-Sequard syndrome. Here, definitely, as you are able to see, that on the side of the damage, the patient is going to have loss of functions like the patient will have loss of joint position, will be loss of fine touch, will be loss of vibration sense, there will be loss of 2-point discrimination, right? So all of these functions are lost. We know joint position, fine touch, vibration, all of these functions are carried by the dorsal column, right? So definitely the patient is actually having loss of dorsal column functions, okay? And therefore there is loss of dorsal column functions on the same side or opposite side, on the same side. So dorsal column damage, okay, ipsilateral loss will be there. Whereas on the opposite side, you are able to see beta, there is loss of pain and temperature. So please remember one thing, that when the lateral column is damaged, beta, there is always a contralateral loss. That means if the right lateral column is damaged, the patient will have problems in the left side. Okay, so because PCD is the mnemonic, pain and temperature are always contralateral, beta. Pain and temperature are always contralateral. So as you are able to see, the damage is on the left side of his body, but he has lost the pain and temperature from the left half, from the right half of his body, beta. Okay. So there is a contralateral loss of pain and temperature, whereas ipsilateral loss of joint position, fine touch, vibration sense, stereognosis, or 2-point discrimination, right? So that has to be remembered. No issues with this, anybody? That is important. Please remember that. This is called as a Brown-Sequard syndrome. Next condition which is there over here, you are able to see this one. What is this? This is nothing else but a tumor, beta, and this tumor is going to have derivatives of all the three germ layers, endoderm, ectoderm, mesoderm. So therefore, it is a teratoma. And this teratoma is actually arising from the sacrococcygeal region. That's the reason why I can call it as the sacrococcygeal teratoma. Important is, please remember, why the sacrococcygeal teratoma forms. It is because of abnormal migration of the germ cells. Okay, the germ cells abnormally migrate in the sacrococcygeal region, leading to formation of the sacrococcygeal teratoma. Whereas if they migrate in the head and the neck region, beta, they will lead to formation of a craniopharyngeal teratoma. Okay, so if it is at the region of the head and neck, that is craniopharyngeal teratoma. If it is in the lumbosacral area, it is a sacrococcygeal teratoma. Next important are these two congenital anomalies. Here you are able to see beta in the first picture, the child's lips are not fused together. So this is a classical case of a cleft lip, right? The first condition which is there, it is a classical case of cleft lip. They usually ask the question, beta, cleft lip is due to inability of fusion of which processes? So please remember, beta, we know that the face is formed by various processes. So if there is no fusion, okay, if there is no fusion or inability of fusion of the medial nasal process with the maxillary process, bache. Okay, if the medial nasal process does not fuse with the maxillary process, then it leads to formation of the cleft lip. And which cleft lip? Lateral cleft lip. If this cleft lip would have been present exactly in the center bit, if this cleft lip would have been present exactly in the center of the philtrum, then it was due to inability of fusion of both the medial nasal processes. When both the medial nasal process do not fuse with each other, that leads to formation of a medial cleft lip exactly in the center. But if there's a lateral cleft lip which is shown in the picture, it is due to inability of fusion of the medial nasal process with the maxillary process. Next picture which is there, but in this image here, you are able to see the palate is not fused together. So this is a classical case of a cleft palate. So this is a classical picture in a case of a cleft palate, beta. If I talk about a cleft palate, please remember it is due to no fusion, or it is due to inability of fusion, beta. It is due to inability of fusion of the maxillary process, okay, of the maxillary process with the palatine process. When the maxillary process and the palatine process definitely do not fuse with each other, okay, properly, that is the condition which will lead to formation of a cleft palate in the patient. Okay. Next important, if I talk about this condition, we know beta that your neural system which is there, the central, the new nervous system which is there, beta, it is formed from a neural tube. As it is a neural tube, beta, it is going to have a anterior opening that is called as the anterior or a cranial neuropore, and a posterior opening that is called as a posterior or a caudal neuropore, beta. Both of these are going to close. So definitely there is fusion, or there is closure of these neuropores, beta. So the anterior neuropore which is there, it is going to close by 25th day after fertilization, beta. It is going to close or fuse by 25th day after fertilization, whereas the posterior neuropore, it is going to close. The posterior neuropore is going to close by 28th day after fertilization. Okay, the posterior neuropore is going to close by 28th day after fertilization. Please be aware of that. Important is, if these neuropores do not fuse with each other, if these neuropores are not going to fuse with each other, bache, they will remain open, and that leads to formation of the neural tube defects, right? That leads to formation of the neural tube defects. This was the picture which was given earlier. What is this condition? We know this condition is nothing else but the anencephaly. And we have to remember that one thing, that anencephaly is the earliest picked congenital anomaly of on an antenatal scan. Yes, when a pregnant female undergoes ultrasound, beta, the earliest congenital anomaly which can be picked up on that scan is anencephaly. It can be picked up as early as 10 weeks period of gestation. It is best picked up by 14 weeks period of gestation, beta. And anencephaly, it was a question that anencephaly is due to inability of fusion of which neuropore. So your answer has to be which, that anencephaly is due to inability of fusion, okay, of the anterior or the cranial neuropore. If the anterior or the cranial neuropore does not fuse, then it leads to formation of anencephaly. Whereas this condition which is there, beta, here you are able to see swelling in the lower back of the child. This condition is known as the spina bifida. The spina bifida which is there, which it is due to inability of fusion. Okay, it is due to inability of closure or fusion of the posterior or the caudal neuropore. If the posterior or the caudal neuropore do not close, then that leads to formation of spina bifida. Spina bifida occulta, which is there, beta, the closed ones. Here the patient will only have depression in the lower back, a dimple from which there will be a tuft of hair arising, or the patient can have swelling as shown in the image below. It can be a meningocele, which will be trans-elimination test positive, or a myelomeningocele, beta, which will be negative for trans-elimination, right? These will be the features seen in a patient of spina bifida. If I talk about the other embryological structures first, then I'll come to tongue. So next is the vitellointestinal duct, beta. We know that this vitellointestinal duct, or the omphallomesenteric duct, okay, this is actually a connection between the mid-gut, okay, this is actually a connection between the mid-gut, beta, and the umbilicus. Okay, so definitely please remember that. We know this is the umbilicus, for example, this is the midgut. Okay, this vitellointestinal duct which is there, beta, it is normally going to close after birth. Yes, it is going to disappear, it is going to obliterate after birth. But in case it does not obliterate, it completely remains open. Okay, it does not obliterate, it completely remains open. In that condition, what is going to happen after birth, beta? Definitely there will be feces passing from the umbilicus. This is a very classical case. If feces are coming out from the umbilicus, that means your whole vitellointestinal duct is completely open. That is called as the vitelline fistula, right? That is known as the vitelline fistula, two-way connection, right? And if they say that chalo, vitellointestinal duct has undergone some obliteration, but still some part of the vitellointestinal duct is patent, beta. And due to that, there is outpouching from the intestine. This outpouching of the intestine, which is present since birth, this congenital diverticulum, which is there, beta, it is known as the Meckel's diverticulum. Okay. Whereas second structure is the urinary bladder. with the urinary bladder and the umbilicus also we have some connection in the fetal life beta. This structure which is there is known as the allantois. This allantois which is there, when it obliterates, it leads to formation of the urachus. Now this allantois or urachus which is there, it should also disappear or it should also obliterate at birth. But in case if it remains completely open, there will be passage of urine. Okay, there will be passage of urine from the umbilicus beta, and if urine is passed from the umbilicus, that means definitely there is form the allantois or the urachus did not disappear. It is completely open. This is called as the urachus fistula beta. Okay, so please remember that. So a vitreointestinal duct, if it is partially patent beta, if there is a partial patency, it leads to formation of a Meckel's diverticulum. Okay, it leads to formation of a Meckel's diverticulum. Whereas if it is completely patent, please remember, it leads to formation of a vitelline fistula. And in case of vitelline fistula, what passes via the umbilicus? It is the feces or the meconium which passes via the umbilicus of the neonate beta. That will be the history. Allantois, which is there beta, please remember that allantois, the remnant is known as urachus. If it remains completely open, definitely urine is going to pass via the umbilicus, and that leads to formation of a urachus fistula beta. No issues with this, anybody? That has to be remembered. Next important is, what are the remnants of these embryological structures? We know beta, the first embryological structure is the umbilical vein. First of all, I hope all of you are quite aware beta, the umbilical cord which is there, it is going to contain one umbilical vein, two umbilical arteries, and the Wharton's jelly along with the vitreointestinal duct. Important is this umbilical vein, also they are two in number beta, but the right umbilical vein is going to disappear, it is going to obliterate. Which umbilical vein will be left behind? So please remember, left is left behind, that we say, that is the left umbilical vein will be left behind beta, it will be there. And when this left umbilical vein obliterates after birth, it leads to formation of ligamentum teres beta, it leads to formation of the ligamentum teres. Next important is the umbilical arteries. If I talk about the umbilical arteries beta, there are two umbilical arteries, the right and the left umbilical artery, definitely. And when these umbilical arteries will undergo obliteration, that leads to formation of a ligamentum arteriosum, which okay, that leads to formation of a ligamentum arteriosum. No issues with this, anybody? That has to be remembered. Next is ductus arteriosus. If I talk about the ductus arteriosus, which is there is a connection between the pulmonary artery and with the arc of aorta beta. So this ductus arteriosus can undergo obliteration after birth, and that leads to formation of ligamentum arterios. That leads to formation of beta. Sorry, just a minute. Umbilical arteries beta. The mnemonic you have to remember is AMUL. That means when umbilical arteries will undergo obliteration, that is going to form the medial umbilical ligament. Yes, that leads to formation of the medial umbilical ligament beta. So please remember, umbilical artery obliteration leads to formation of the medial umbilical ligaments. Whereas if they ask you the ductus arteriosus, that ductus arteriosus, when it undergoes obliteration, that leads to formation of the ligamentum arteriosum. Okay? That leads to formation of the ligamentum arteriosum. That has to be remembered. If they say better ductus venosus, which is there, the ductus venosus, sorry, if it undergoes obliteration, it leads to formation of the ligament. Sorry, it leads to formation of the ligamentum venosum, bache. It leads to formation of the ligamentum venosum. And the foramen ovale, which is a connection between the right and the left atria, when it undergoes obliteration, it leads to formation of the fossa ovalis. It leads to formation of the fossa ovalis. Okay? So that has to be remembered. Next important is, if they ask you urachus, which is there, when it undergoes obliteration, it leads to formation of which remnant? So it leads to formation of the median umbilical ligament. Okay, so you will be confused with medial and median. So always remember this U and N beta. When you reverse the U, it becomes N. So urachus leads to formation of median umbilical ligament, and umbilical arteries leads to formation of the medial umbilical ligaments beta. Okay, so that has to be remembered. Next important is the tongue. We have to remember the innervation of the tongue beta. This is the anterior 2/3 of the tongue that you have to remember. Okay, this is the anterior 2/3 of the tongue. This is the posterior 1/3 of the tongue, which is this is the posterior 1/3 of the tongue. And then we have the posterior most part of the tongue as well, the vallecula, which is there. The anterior 2/3, the nerves which are going to innervate the tongue, or the nerves which are going to carry sensations from the tongue, are remembered as 5, 7, 9, and 10 beta. Yes. So definitely, the anterior 2/3 of the tongue, there are two kinds of sensation: the taste sensation and the general sensation. So here, from the anterior 2/3 of the tongue, the general sensation like pain, temperature, touch, and pressure beta, these general sensations are usually carried by the fifth cranial nerve. Fifth cranial nerve is the trigeminal nerve. Which branch of trigeminal? The mandibular nerve. And which branch of mandibular nerve exactly? The lingual nerve. By the name itself, it is evident, lingual. Okay, so general sensations from the anterior two-third of the tongue are carried by the lingual nerve beta, which in turn is a branch of the trigeminal nerve. And the taste sensations from the anterior two-third of the tongue. The taste sensation from the anterior two-third of the tongue is carried by the chorda tympani nerve beta. Okay, it is known as the chorda tympani nerve, which is going to carry the sensation, which is actually going to be the branch of the facial nerve itself. If I talk about the posterior one-third of the tongue, it's easy over here. The general as well as the taste sensation, both are carried by the branch of ninth cranial nerve, that is your glossopharyngeal nerve beta. And from the posterior most part of the tongue, also it's easy. From the posterior most part of the tongue, the general as well as the taste sensations are carried by the same nerve beta, the branch of the vagus nerve, that is your 10th cranial nerve. Okay, so it is 5, 7, 9, and 10. You have to remember that. Okay, so anterior two-third general sensations by lingual nerve, taste sensations by chorda tympani. Posterior one-third, both sensations by 9th cranial nerve, that is glossopharyngeal. And posterior most part of the tongue, both sensations by 10th cranial nerve, that is your vagus nerve. Okay, next important beta over here. These are the planes which are going to divide your body. The first plane, they can give you any plane in the picture. The first plane which is there, you are able to see. It divides your body into anterior and posterior halves. Right? It divides your body into the anterior and the posterior half. This is known as the coronal plane beta. Please remember this plane is known as the coronal plane over here. Okay. Next plane which is there that I'm highlighting now in red in color. This plane is going to divide the body into the right and the left half. The plane that divides the body into the right and the left half beta is known as the sagittal plane. Please remember that. It is known as the sagittal plane. And lastly, the third plane which is there beta, it is actually going to divide your body into the upper and the lower half. The plane which is going to divide the body into the upper and lower half, it is known as the transverse plane. No issues with this, anybody? Please remember that. Now, if I talk about the one important landmark known as the anatomical snuff box beta. So when you extend your thumb now, below your thumb, you are going to see a depression. That depression is what is called as the anatomical snuff box beta. Okay, this is the thumb just below the thumb. This is the space where you are able to see the anatomical snuff box. Try to abduct and extend your thumb, you will be able to see the depression. That is the anatomical snuff box. Now, how to remember the medial border of the anatomical snuff box beta? The medial border of the anatomical snuff box, which is there, it is formed by the extensor pollicis longus tendon, APL. Yes, it is formed by the EPL, that is extensor pollicis longus tendon. The lateral border, which is there, beta, the lateral border is formed by extensor pollicis brevis and the abductor pollicis longus tendon. How to easily remember that? If you move the thumb laterally, beta, if you move the thumb laterally, that is called as abduction or adduction. Obviously, it is called as abduction. And when you do abduction, which muscle is going to help? The abductor muscle, right? So it is abductor pollicis longus. So now lateral border, now definitely lateral movement, it is abductor. So lateral border is formed by the abductor pollicis longus beta. And if one is longus, the other should be brevis. So abductor pollicis longus and extensor pollicis brevis forms the lateral boundary. That's clear. Now, obviously, if extensor pollicis brevis is forming the lateral boundary, who will be on the medial side then? The extensor pollicis longus tendon. Got it? So that's how you can easily remember that. Okay? Proximal part, which is the floor, which is there, beta. Sorry, the floor of the anatomical snuff box is mainly formed by the carpal bones, beta. Yes, which carpal bones? Mainly the scaphoid and the trapezium. So whenever there is fracture of the scaphoid and trapezium, beta, patient can actually have problems or pain in the anatomical snuff box, beta. Okay? If I talk about the contents of the anatomical snuff box, the most important, you have to remember, the most important content of the anatomical snuff box is the radial artery. Okay, so radial artery is the content of the anatomical snuff box. Apart from that, cephalic vein, usually some books say content, but mainly it is the roof of the anatomical snuff box. Skin, subcutaneous tissue, and the cephalic vein, they usually form the roof of the anatomical snuff box. So if you want to mark single best answer for content, answer has to be the radial artery beta. Okay, so that's important. Next important, if I talk about the humerus and the arteries or the nerves which are related to it. Now, first beta, if there is fracture at the surgical neck of the humerus, if there is any fracture at the surgical neck of the humerus, beta, one nerve is going to take a turn around the surgical neck, known as the axillary nerve, and one artery known as the posterior circumflex humeral artery. So there will be damage to the axillary nerve or the posterior circumflex humeral artery, which is okay. And whenever there will be damage to the axillary nerve, what is the root value of this nerve, beta? The axillary nerve root value C5, C6. Whenever there will be damage, there will be loss of or there will be weakness or paralysis of which two muscles? Definitely there will be loss of function of the deltoid muscle, and the second one being the teres minor muscle, beta. So deltoid and teres minor are the two muscles which are supplied by the axillary nerve. So the patient will have weakness or loss of functions of these muscles. What is the main function of the deltoid? We know, beta, it is mainly responsible for abduction of the lateral movement of your arm. So the abduction of your arm, beta, when you move the arm away from your body, that is abduction. 0 to 15 degree, 0 to 15, 1 5. Okay, so 0 to 15-degree abduction is done by the supraspinatus muscle, beta. 0 to 15 by supraspinatus. 15 to 90 degrees is done by the deltoid muscle. Yes, so definitely it is responsible for abduction between 15 to 90 degree, and above 90 degree, beta, it is done by trapezius and the serratus anterior muscle. Yes, above 90 degree or overhead, the abduction is done by serratus anterior and the trapezius muscle. So if there is palsy of the deltoid muscle, there will be loss of abduction between 15 to 90 degree, rather the whole abduction. Reason is deltoid is main abductor between this degrees, but otherwise it is going to always help the abduction. The whole abduction is helped with the helped by the deltoid itself. Along with that, the patient will have loss of sensation, beta, on the upper lateral part of the arm. When there is loss of sensation on the upper lateral part of arm, where the army people wore their regimental badges, this is what is called as regimental badge sign. Anesthesia or loss of sensation in the upper lateral arm, known as the regimental badge sign, beta. Okay. Next important is this part, beta. If there is a fracture in the mid shaft of the humerus, if there is fracture in the mid shaft of the humerus, beta, please remember, on the posterior surface of the humerus shaft, we have the radial groove of the spiral groove. And what passes via it? It is the radial nerve which passes, and the profunda brachii artery. So there is going to be damage to the radial nerve and the profunda brachii artery, beta. So that's the reason. If there is radial nerve damage, what is the root value of radial nerve? Just like brachial plexus, beta, the root value of the radial nerve will be C5, C6, C7, C8, and T1. Yes, the whole value of the brachial plexus is same for the radial as well as the medial nerve, beta. Important is, if the radial nerve gets damaged, definitely we know radial nerve is going to supply the posterior part of your arm and forearm. That's the reason the patient will have palsy of all the extensor muscles. That's the reason you are not able to dorsiflex, or you are not able to extend the wrist. If you are not able to extend the wrist, that is what is called as a wrist drop, beta. Yes, that is known as the wrist drop. Which kind of splint will be used? It is a dynamic cock-up splint, which is used in the radial nerve palsy in the patient. Next is the supracondylar fracture, which is supracondylar fracture may definitely, here you have to remember one thing: in supracondylar fractures, there is damage to which artery? There is damage to the brachial artery and the median nerve, beta. There is damage to the brachial artery and the median nerve. Okay? So definitely the median nerve of the patient gets damaged or compressed over here. What is the root value of median nerve? We know the root value of median nerve is again C5, C6, C8, C7, C8, and T1, beta. Okay, so median nerve, when it is damaged, it can lead to various deformities. It can lead to the ape thumb deformity, beta, when the thumb is not able to oppose the fingers, when the thumb is not able to abduct. Okay, so thumb comes to lie in the same position or same plane as the other fingers. That is called as ape thumb deformity. Or the patient will have the pointing index sign, beta. Okay, the patient will have a pointing index sign, or the patient will have that Pope's hand or the hand of benediction, right? The patient will have a Pope's hand or the hand of benediction deformity. These will be the deformities which can be seen in the patient, beta. Okay, so that's important. Next important is, when there is fracture of the medial epicondyle of the humerus. Commonly repeated question. If there is fracture of the medial epicondyle of the humerus, beta, in this condition you have to be aware that in behind the medial epicondyle we have the ulnar nerve. So there will be damage to the ulnar nerve and the ulnar collateral artery. Okay, so there is damage to the ulnar nerve and the ulnar collateral artery. What is the root value of ulnar nerve? Ulnar nerve ka root value is C8, T1. If C7 is in the bracket, then that will be the best answer. Brackets में C7, C8, and T1. But C8 and T1 are the usual values we can say of the ulnar nerve. When the ulnar nerve gets damaged, beta, the patient is going to have complete or a partial claw hand. There will be a partial claw hand in the patient, beta. Okay, the complete claw hand is due to median plus the ulnar nerve injury. Complete claw hand is due to median plus ulnar nerve injury, and partial claw hand is due to ulnar nerve injury alone. And in this condition, which kind of splint will be used? It is a knuckle bender splint which will be used in ulnar nerve damage, beta. Okay, so that has to be remembered. And we know common peroneal nerve is usually damaged whenever there is fracture at the lateral tibial condyle, or at whenever there is a fracture of the neck of the fibula, beta, because this common peroneal nerve takes a turn around the neck of fibula. So in lateral tibial condylar fracture, known as the bumper's fracture or the fibular neck fracture, there will be common peroneal nerve injury. And whenever there is injury to the common peroneal nerve or the deep peroneal nerve, the patient is going to have palsy of tibialis anterior muscle, and as the tibialis anterior muscle is paralyzed, beta, the patient is not able to do a dorsiflexion of the foot. The patient is not able to do the upward movement of the foot, and that is called as a foot drop deformity. For that, we are going to use the AF ankle foot orthosis. Okay, this is the X-ray of the foot, beta, which is commonly asked in the examination. You have to remember this boat-shaped bone, which is there, beta. This boat-shaped bone is which tarsal bone? It is nothing else but your navicular bone, beta. Okay, it is a navicular bone. Just beside the navicular bone, this cube-shaped bone, which is there, beta, it is nothing else but your cuboid bone. Okay, in front of the navicular bone, you have three small bones, beta, and these three small bones which are there, they are nothing else but the cuneiform bone. It is the lateral cuneiform, the intermediate cuneiform, and the medial cuneiform bone which is there. Then behind this, beta, here this bone which is there is the talus bone, and beneath the talus, the largest tarsal bone which forms the heel bone as well. This is called as a calcaneum as well. Okay. So above we have the talus which forms connections with the tibia fibula, and below that definitely you have the calcaneum bone. Okay. Next important, what is this deformity called as? This deformity which is there, beta, it is known as the winging of scapula. Okay, so this deformity which is there is known as the winging of scapula, and we know that winging of scapula is due to damage to which nerve? It is due to damage to the long thoracic nerve. This long thoracic nerve is also known as the nerve of Bell. So if there is palsy or damage to the long thoracic nerve, which that leads to palsy or paralysis of the serratus anterior muscle, which is also known as the boxer's muscle. And as the serratus anterior muscle of the patient is paralyzed, that's the reason why the patient will have this winging of scapula. There will be protrusion of the scapula, as you can see. Next condition which is there, beta, over here. This is a commonly repeated exam question. Here you can see between the Achilles tendon and the medial malleolus. If the examiner is palpating the artery, the artery which is there, beta, it is going to be the posterior tibial artery itself. Okay, so here in this side, definitely we are going to palpate the posterior tibial artery. Whereas definitely if I say that in on the okay on the navicular bone or between the first and the second metatarsal, on the navicular bone or between the first and the second metatarsal, beta, if you try to palpate the artery, that artery is definitely going to be the, please remember, that artery is definitely going to be what? It is going to be your dorsalis pedis artery, which is, so please remember that. Against navicular or between first and second metatarsal, posterior, it is dorsalis pedis. Between tendo Achilles and medial malleolus, it is the posterior tibial artery. Next important over here, beta, you are able to see these are the carpal bones, and above that we have the flexor retinaculum. Between the carpal bones and the flexor retinaculum, this canal which is formed, beta, is nothing else but your carpal tunnel. Okay, this canal which is formed is nothing else but your carpal tunnel. What passes by the carpal tunnel? We know the main nerve which passes by the carpal tunnel is definitely the median nerve, beta. You have to remember that. Apart from that, there are four tendons of the flexor digitorum superficialis. There are four tendons of the flexor digitorum profundus, one tendon of flexor carpi ulnaris, and one tendon of the palmaris. So all these 10 tendons are going to pass via the carpal tunnel, beta. At least remember, whenever there will be damage or compression in the carpal tunnel, the patient is going to have median nerve compression, beta, median nerve palsy. Next important, and that is called as a carpal tunnel syndrome. Okay, so please remember, in carpal tunnel syndrome, the patient is going to have compression or injury to the median nerve. Okay, that's the funda. Whereas second, if I talk about, beta, here above the flexor retinaculum and between the pisohamate ligament. So above the flexor retinaculum or the pisohamate ligament, this canal which is there, beta, it is called as a Guyon's canal or the ulnar nerve canal. This is the Guyon's or the ulnar nerve canal, and here the patient is going to have damage to the ulnar nerve. Here the patient is actually going to have damage to the ulnar nerve. That has to be remembered. No issues with this, anybody? So ulnar nerve compression will be seen in Guyon's canal syndrome. Okay. Next important, this is nothing else but the circle of Phyllis, beta. So we know circle of Phyllis is formed by what? So first of all, we have this internal carotid artery, beta, the largest branch, and internal carotid artery ka first branch which is there, beta, it is going to arise. That is known as the ophthalmic artery, right? Then definitely the largest or the terminal branch of the internal carotid artery is known as the middle cerebral artery, beta. Okay, so internal carotid artery gives away the ophthalmic artery, gives away the anterior cerebral artery, and then it forms the middle cerebral artery. So the other branches of the internal carotid artery will be the anterior cerebral artery. Both these anterior cerebral artery, which they are connected by the small artery known as the anterior communicating artery, beta. And this anterior communicating artery aneurysms can also cause compression of the optic chiasma, leading to bitemporal hemianopia in the patient, and this is the most common site or the most common artery to rupture in case of berry aneurysm rupture in a patient of subarachnoid hemorrhage. Next important beta, here you are able to see the two vertebral arteries. These two vertebral arteries which are there, they are going to combine to form a single basilar artery, and this basilar artery will again divide to form the two posterior cerebral arteries. These posterior cerebral arteries are connected to the internal carotid artery with the help of the posterior communicating arteries. Okay? If they ask you which arteries are the part of circle of Willis, you have to understand first the internal carotid artery, second the anterior cerebral artery, third the anterior communicating artery, fourth the posterior cerebral artery, and fifth the posterior communicating artery. Yes, only these five arteries are a part of the circle of Willis, beta. So please remember, middle cerebral artery or the ophthalmic artery, they are never the part of the circle of Willis. Please remember that. Okay? So that has to be remembered. We know that the basilar artery or this ICA or PICA, the anterior inferior cerebral artery, the posterior inferior cerebellar artery, or the vertebral artery for that matter, all of them are going to supply the brainstem area. Even this anterior spinal artery is going to supply the brainstem area. We have discussed about the syndromes earlier in medicine, okay? So I have told you that. If I talk about the joints now, beta, sorry, there are three types of joints, beta. The immovable joints are called as the fibrous joint. The partially movable joints are called as the cartilaginous joints, and the freely movable joints are called as the synovial joints. If I talk about the immovable or the fibrous joints, there are three types of fibrous joints. First, definitely is the suture. Yes, the joints between the two cranial bones, which is there, it is the sutures. The first one, which is there between the two parietal bones, is known as the sagittal suture. The suture between the frontal bone and the parietal bone is known as the coronal suture, and the suture between the parietal and the occipital bone is known as the lambdoid suture, and the suture between the two frontal bones is known as the metopic suture, beta. So all of these sutures are fibrous joints. Next is syndesmosis. Syndesmosis means if there is a interosseous membrane between the two bones, beta, which is causing the joint formation, that is called as a syndesmosis. We know such type of syndesmosis which is there, it is present in the middle radioulnar joint and the superior and inferior tibiofibular joint. Yes, so middle radioulnar joint and the superior and the inferior tibiofibular joints are examples of syndesmosis. Next is the gum fossils, beta. Gum fossils definitely the joint between the tooth and the socket which is there, that is what is known as the gum fossils. Please remember that. Next, if I talk about the cartilaginous joints, cartilaginous joints are either primary cartilaginous joints or secondary cartilaginous joints. The primary cartilaginous joints are called as the synchondroses. Okay, they are actually joined with the help of the hyaline cartilage, whereas the secondary cartilaginous joints are called as symphysis. They are joined with the help of the fibrocartilage. Now, if I talk about the primary cartilaginous joints, also called as synchondroses, the best example for them is the epiphyseal metaphyseal joint. Yes, the epiphyseal metaphyseal joint, beta, the joint between the epiphysis and metaphysis is an example of primary cartilaginous joints, right? So that has to be remembered. Whereas secondary cartilaginous joint, it has to be remembered as a symphysis. That is nothing else but the pubic symphysis, beta. The pubic symphysis, they always give a hip X-ray. They usually mark the pubic symphysis area and they ask which kind of joint it is. It is the secondary cartilaginous joint, beta. Okay. Next, we have the synovial joints. Synovial joints are the ones where there will be presence of synovial fluid, and these will be the freely movable joints. These are of six subtypes. First one is the plane joints, beta. Plane, that means both the surface of the bones, beta. The both surface of the bones is definitely plane. They are gliding on each other. Okay. So these type of joints are nothing else but the intertarsal or the intercarpal joint. The joint between the two tarsal bones or the two carpal bones are the plane or the gliding joints. Next is the hinge joint. Hinge joint, beta, is the joint where movement is possible only in one direction. You cannot move the joint in another direction. The first one to be remembered is the elbow joint, beta, and second is the ankle joint. Elbow and ankle joint are the best examples of the hinge joint. Knee joint, a lot of people say yes. Knee joint, beta, if you have compound joint in the option, then that will be the best answer. Reason is knee joint is not only one type of joint, it is a hinge joint. Along with that, it is also a condyloid joint, beta. Okay, it is a hinge as well as the condyloid joint. That's the reason why you have to remember that knee joint is a compound joint together. Okay. Next important, the third type of joint is a pivot joint. Pivot joint is what, beta? When one bone actually rotates around another bone. When one bone is going to rotate around the another bone, that is called as a pivot or the rotating joint. This pivot or rotating joint, the best examples for it is, beta, it is nothing else but the superior and the inferior radioulnar joint and the middle tibiofibular joint. Yes, it is vice versa now from syndesmosis. Here it is the superior and the inferior radioulnar joints and the middle tibiofibular joint. All are examples of pivot joint, beta. Next, or the atlantoaxial joint also, the C1, C2 joint between the first and the second cervical vertebra, atlantoaxial, that is also an example of pivot joint. Next is the condyloid joint. Condyloid joints are also called as the ellipsoid joint. Condyloid or the ellipsoid joint, I've told you that knee joint also has one part of condyloid or the ellipsoid joint itself, beta. Okay, so that's the important thing that you need to remember. Saddle or the sellar joint, beta. Saddle or sellar joint, if I talk about, it is the incudomalleolar joint in the ear, beta. Okay, the incudomalleolar joint which is there between the incus and the malleus is a saddle or a sellar joint. And the best example to be remembered is the first CMC joint, beta. CMC is nothing but the first carpo-metacarpal joint. Yes, the joint below the thumb which is there between the carpal bone and the metacarpal of the thumb. That is an example of saddle or sellar joint. Next is the ball and socket joint. Ball and socket joint, the best examples are hip and the shoulder joint. Yes, ball and socket, the best examples are hip and the shoulder joints. Next, this is the NCCT and they ask you, they mark you any structure every time, they ask you what is the structure. So first, identify the structure beta. These are nothing else but the lateral ventricles, okay? So now if I talk about the structure which is just beside the lateral ventricle beta, okay, the structure which is just beside the lateral ventricle. So here you just have to remember these green color structures that I'm marking is known as the caudate nucleus beta. And whenever there is damage to the caudate nucleus, patient is actually going to have what? The patient is going to suffer from chorea. Next important beta, just behind the caudate nucleus which is there, this pink color structure that I'm drawing beta, the pink color structure, this pink color structure which just the pink color structure that I'm drawing is a dense collection of fibers called as the internal capsule beta. It is a dense collection of fibers known as the internal capsule. If they mark inside the internal capsule, if they mark this area inside the internal capsule beta, okay, that I am highlighting that this structure that they are marking beta, it looks like the lens, right? This structure which is there beta, it looks like the lens itself. And as it looks like the lens, this is known as the lens like, that is a lentiform nucleus beta. This is known as the lens like, that is a lentiform nucleus. And obviously outside this will be your external capsule. Outside this is going to be your external capsule beta. Just behind the internal capsule which is there, just behind the internal capsule which is there beta, if they mark area, this area over here, this is nothing else but the thalamus. Please remember this area which is there is nothing else but the thalamus. If they mark inside the ventricle, a calcified gland they have marked last time, that is nothing else but the pineal gland beta. Please remember that will be called as the pineal gland. Okay, so that is important to be remembered. If I talk about the CSF, how does it flows now? So first thing important beta, CSF is again a ultrafiltrate of the blood or the plasma itself. Okay, so it is formed by the capillaries itself. And this network of capillaries which forms the CSF beta is nothing else but the choroid plexus. And where is the choroid plexus located? So it is located inside the lateral ventricles beta. There are two lateral ventricles in the brain in which we will have a network of capillaries, and these network of capillaries are known as the choroid plexus. These choroid plexus are going to form the CSF or the cerebrospinal fluid. Once it is formed by the lateral ventricles beta, it will travel into the third ventricle. Yes, it will travel beta into the third ventricle, and it is going to travel into the third ventricle by the foramen of Monro beta. Please remember, it is going to travel into the third ventricle by the foramen of Monro. From the third ventricle beta, it is going to travel to the fourth ventricle, and via the third to fourth ventricle, it travels via the aqueduct of Sylvius beta. Yes, it travels via the aqueduct of Sylvius. Please remember that. Now from fourth ventricle, actually, okay, please remember from the fourth ventricle beta, 1/3 of the CSF which is there, the 1/3 of the CSF is going to go to the central canal. Yes, 1/3 CSF goes to the central canal of the spinal cord by the cisterna magna. And most important, the 2/3 rest of the CSF which is there beta, the rest 2/3 of the CSF, it is going to go into the subarachnoid space. In the subarachnoid space, it will get absorbed by the arachnoid villi and the granulations. Yes, in subarachnoid space, it will get absorbed by the arachnoid villi and the granulations. It will go from the fourth ventricle into the subarachnoid space, which is via the foramen of Luschka and the foramen of Magendie. Okay, it goes into the foramens via the foramen of Luschka and the foramen of Magendie. Please remember that. No issues with this, anybody? That's important to be remembered. Okay. Next, if I talk about the important one-liners, number of branches which are given by the cervical part of internal carotid artery. When the internal carotid artery passes by the neck, it gives beta 0 branches. Yes, external carotid artery gives 5 branches in the neck, but internal carotid gives 0 branches in the neck beta. It is going to supply the brain of the patient. Right border of the heart, if they ask you beta. So please remember the right border of the heart if they ask you anatomically. So right border of the heart is only formed by the right atrium. Right border of the heart is only formed by the right atrium. But if they ask you the right border of the cardiac shadow, then definitely I can say the right cardiac shadow. If they ask you which, the right cardiac shadow is formed by the 3 structures. Sir, what is sir? S for superior vena cava, I for inferior vena cava, and R for right atrium. Okay, so right border of the heart is only formed by the right atrium, but the right cardiac shadow is definitely formed by the superior vena cava, inferior vena cava, and the right atrium. Then if they ask you about dominance in the coronary circulation, how do we decide that which coronary artery is the dominant circulation, whether it is the right or the left? So please remember, beta, 60% cases में the dominance in the coronary circulation is decided by the origin of the PDA, beta. What is PDA? The posterior descending artery or the posterior interventricular artery. So this posterior descending artery or the posterior interventricular artery, beta, in 60% cases it is going to arise from the right coronary artery, and in rest of the cases it can arise from the left coronary artery. Okay. So therefore, if they ask you that dominance in coronary circulation is more commonly right coronary, sorry, right, more commonly it is the right dominance, beta. So right sided dominance. Okay. If they ask you thymus lies in which part of the mediastinum, so please answer it as thymus lies in the superior mediastinum, beta. Thymus is the gland which is responsible for maturation of the T cells or the T lymphocytes, beta, whereas the B lymphocytes are going to mature inside the bone marrow itself. That's the reason the name comes. Okay, the T lymphocytes mature in thymus and B lymphocytes in the bone marrow. Okay, so important is this. Thymus is also going to have specialized cells known as the Hazel's corpuscles, beta. Okay, so please remember, an esophagus which is there, beta, it lies in the posterior mediastinum. Esophagus usually lies in the posterior mediastinum. If the thymus is absent, that leads to a condition known as the D-George syndrome, beta. Okay, so D-George syndrome, catch 22 is the mnemonic. Cleft palate, abnormal feces, thymus hypoplasia or thymus aplasia, then definitely cardiac anomalies, hypocalcemia, and microdeletion on chromosome number 22. Bifurcation of the trachea is at which level, beta? So please remember, bifurcation of the trachea is at T4 or T6. That means in living individuals is at T6, beta. In a cadaver, it is at the level of T4. Spleen develops by, so please remember, the spleen is going to develop by the dorsal mesogastrium, beta. Spleen is going to develop by endocrine and embryological structure known as dorsal mesogastrium. And please remember, spleen is an organ which does not form the bed of the stomach. Yes, spleen does not form any kind of bed of the stomach. That has to be remembered. If they say parotid gland is innervated by, so please remember, parotid gland has one kind of relation with facial nerve. That means it says, "Ki I love you, but as a friend." What do I mean by that? The facial nerve usually goes inside the parotid gland, but it does not supply. It does not even give one branch to the parotid gland. So the parotid gland is mainly supplied by the ninth cranial nerve, that is your glossopharyngeal nerve, beta. Whereas the secretomotor fibers which are there, the secretomotor fibers, that means the ones which are going to stimulate the parothyroid gland for salivary secretion, that is definitely given by the auriculotemporal nerve. And we know whenever we do a parotid surgery and there is damage to the auriculotemporal nerve, and when this auriculotemporal nerve abnormally recovers, and then the patient will have sweating and flushing, that is redness and sweating on the cheek after eating spicy food. That condition is known as the Fraze syndrome. That Fraze syndrome is due to abnormal recovery of the auriculotemporal nerve itself. Next important, if they ask you, beta, what is the dangerous area of scalp? We know scalp is an abbreviation in itself, beta. There are 5 layers in the scalp, the outermost being the skin, then the dense connective tissue, then we have the aponeurosis there, known as the Gilia aponeurotica, then we have the loose areolar tissue, and lastly we have the periosteum, beta. So if they ask you which is the most dangerous layer of scalp, answer has to be the loose areolar tissue. Reason is it contains the emissary veins. So if there is damage, there will be a subdural hemorrhage. That is one reason. But main important reason is, via these emissary veins, beta, the infection can directly travel to the cavernous sinus, leading to cavernous sinus thrombosis. Therefore, loose areolar tissue is considered as the most dangerous area of the scalp. Next, if they ask you, beta, the largest sesamoid bone, definitely. So please remember, the largest sesamoid bone which is there, it is formed in which muscle? So please remember, beta, the largest sesamoid bone is nothing as but the patella. I hope all of you are quite aware that what is a sesamoid bone. Sesamoid bone is the one definitely which is ossified in the tendon of a muscle, beta. The bone which ossifies in the tendon of a muscle is known as sesamoid. And the largest sesamoid bone is patella, definitely. And that patella which is there, beta, it ossifies in the tendon of a muscle known as quadriceps femoris. Yes, it ossifies in the tendon of a muscle known as the quadriceps femoris, which. Okay, so that I remembered. Okay, so please remember that. Piriformis is a carpal bone, beta, which is also a sesamoid bone, and that piriformis usually ossifies within the tendon of the flexor carpi ulnaris muscle, FCU. Okay, flexor carpi ulnaris. Important is, if they ask you, this is a Sarkari question of your examination, that spinal cord ends at which level? We know spinal cord of adult usually is around 45 centimeters, and that spinal cord in adults is going to end at which level? The spinal cord in adult is going to end at the lower border of L1 vertebra, which please remember that. Whereas if they ask you that spinal cord in infants is going to end at which level of the spinal cord in infants is going to end at the lower border of the upper border of the L3 vertebra, the spinal cord in infants. Next important, if they ask you, beta, the largest commissural fibers in the brain are. So we know commissural fibers are the ones which are going to connect the right and the left half of the brain, beta. Yes, the right and the left cerebral hemispheres. So we know the right and the left cerebral hemispheres are usually connected by the corpus callosum. So largest commissural fibers in the brain are nothing else but the corpus callosum itself. Please remember that there are four parts of the corpus callosum. We have the rostrum, then we have the genu, that is the bend, then we have the body and the splenium. So rostrum, genu, body and splenium. Rostrum, genu, body and splenium are the four parts of the corpus callosum, beta. Next, if they ask you that which epithelium is going to line in the ducts, the thighs and testes, so that germline usually lined by the cuboidal epithelium. Yes, it is lined by the cuboidal epithelium. Please remember that. It is lined by the cuboidal epithelium. No issues with this. Next important, if they ask you, Hazel's corpuscles. I've already told you Hazel's corpuscles are the specialized cells which are seen in the thymus, beta. They are the specialized cells of the thymus. Next important, malphizian corpuscles, if they ask you that malphizian corpuscles which are there, they are seen in. Malphizian layer is seen in skin, but malphizian corpuscles, if they ask you, beta, they are seen in the kidneys and they are actually seen in the ducts of Bellini. Yes. They are usually seen in the ducts of Bellini after collecting tubules. Please remember that. Next, if they ask you, tympanic membrane is derived from which germ layer? So we know, beta, the tympanic membrane which is there, it is derived from all the three germ layers. Yes, the ectoderm, endoderm, tympanic membrane. Okay, so please remember, malleus, we know malleus and incus both are derived from the first arc, whereas the stapes is derived from the second arc, beta. Okay, the tensor tympani muscle, again, it is derived from the first arc because it is attached to the malleus, and the stapedius muscle, okay, it is attached to the stapes, therefore it is derived from the second arc. If they ask you most common site of foreign body in the lung, we know, beta, the right-sided bronchus which is there, the right-sided bronchus is going to be straight and it is going to be more wider. As the right-sided bronchus are straight and wide, that is the right lower lobe. Okay, it is the right lower lobe because foreign body straight goes into the right lower lobe of the lung itself. Next important, if they ask you the abductors of the hip joint. Abductor is the outward movement of the hip joint, bache. So if they ask you abductor of the hip joint, then your answer has to be, beta. The main abductors of your hip joint is nothing else but the gluteus minimus and the gluteus medius muscle. Okay, the gluteus minimus and the gluteus medius muscle, beta. Okay, these are the abductors of your hip joint, bache. And definitely in these joints, these muscles which are there, the gluteus minimus and the gluteus medius, definitely here, they both are supplied by the superior gluteal nerve. Okay, so whenever the superior gluteal nerve will be compressed or injured, beta, there will be palsy of the gluteus minimus and medius, and then the patient will have which test? Definitely the Trendelenburg's test will be positive, beta. Next is the unlocking of the knee joint. Unlocking of the knee joint is done by which muscle? So you can try when you do flexion of the knee joint, beta, there is unlocking of the knee. When you do flexion of the leg, there is unlocking of the knee joint. So at this time, definitely the muscle which is working is the popliteus muscle. But at the same time, beta, you can try when you do extension of your leg. When you do extension of the leg, at that time, definitely there is locking of the knee joint. And when there is locking of the knee joint, the anterior muscle is contracting. That is nothing as but the quadriceps femoris. Yes, that muscle is the locking muscle of your knee joint. All muscles of the tongue, beta, please remember, all muscles of the tongue, glossopharyngeal nerve, right? Sorry, the hypoglossal nerve, beta, except the palatoglossus muscle, which is innervated by the vagus nerve. Actually, it is not the vagus nerve, it is a network, beta, so it is called as the vagus plexus. Okay? So all muscles of tongue innervated by 12th cranial nerve, the hypoglossal nerve, except palatoglossus muscle, which is supplied by the vagus plexus. Important is, whenever there will be a 12th cranial nerve or whenever there will be a hypoglossal nerve palsy, beta, in that condition, please remember one thing. Whenever there is a 12th cranial nerve or hypoglossal nerve palsy, the patient will have a ipsilateral movement of the tongue. Yes. Okay, or ipsilateral deviation of the tongue. What do I mean by this? Whenever there is a 12th muscle palsy, the tongue will be deviated to the same side of the injury. That means if there is a right-sided hypoglossal nerve palsy, the tongue will be deviated towards the right side itself, beta. Okay, so ipsilateral, the same-sided palsy, the same-sided deviation will be there. Next important, if I talk about the blood-testis barrier, which is there, beta. So please remember the blood-testis barrier is usually formed by the Sertoli cells. Yes, the Sertoli cells we know which are present inside the seminiferous tubules of the testis, beta. So these Sertoli cells are going to provide nourishment to the sperms as well. They are also called as the nursing cells. Apart from that, they also are responsible for secretion of inhibin in males beta, and that is also responsible for formation of the blood testis barrier. The blood-brain barrier is usually formed by the astrocytes. The blood-brain barrier by the astrocytes. Which structure maintains the uterine axis? First of all, what is the normal uterine axis, beta? The normal uterine axis is anteverted and antiflexed. Okay, the normal uterine axis is anteverted and antiflexed, and the structure which can actually help in maintaining the uterine axis is nothing else but the round ligament. The structure which maintains the uterine axis is the round ligament of the uterus. Next, when you strike beta, when you strike the upper medial thigh, the testis gets elevated. This reflex is mediated by which nerve? So when you strike the upper medial thigh, the testis or the scrotum is elevated. This reflex, which is there beta, is known as the cremasteric reflex. Okay, this reflex is known as the cremasteric reflex, and this cremasteric reflex, which is there beta, it is due to the genitofemoral nerve. Yes, it is due to the genitofemoral nerve beta. Please remember that. Next, dilatation of the superior and the inferior epigastric vein leads to. So the superior and the inferior epigastric vein, when there is a lot of pressure inside these vessels and when they undergo dilatation beta, they are going to form the classical caput medusae. So in a patient of portal hypertension beta, whenever the pressure inside these veins is going to increase, the patient will form the caput medusae beta, dilated tortuous veins around the umbilicus. Transpyloric plane, if they ask you about the transpyloric plane, it passes at which level? So please remember the transpyloric plane, which is there, it is going to pass at the level of L1. If they ask you transtubercular plane is going to pass at which level? So transtubercular plane passes at the junction of the L4, L5 beta. Transtubercular plane passes at the junction of the L4, L5. If they ask you the subcostal plane below the ribcage, if they ask you the subcostal plane, that usually passes at the level of the L3. Then left gonadal and the left suprarenal vein beta. The left gonadal, that is the ovarian or the testicular. So that left gonadal and the left suprarenal vein, both of them drain into the left renal vein beta. So please remember, right-sided gonadal vein and the right-sided suprarenal vein directly drains into the inferior vena cava, but the left gonadal vein and left suprarenal vein first drains into the left renal vein, which then in turn drains into the inferior vena cava. The Paneth cells are located within. So please remember, beta, the Paneth cells are located within the intestinal epithelium. Yes, in the intestine, mainly in the small intestine beta, we have these Paneth cells. And what is the function of these Paneth cells? That was also a question. Paneth cells are actually going to secrete lysozymes. And these lysozymes which are there, bache, these lysozymes are actually going to fight the infections usually. Okay, so these are definitely going to help fight the infection or provide local immunity. Circular folds which are there, beta, in the intestinal mucosa, they are called as. So please remember the circular folds in the intestinal mucosa, they are called as the valvulae coniventus. Yes, the circular folds in intestinal mucosa are known as the valvulae coniventus, or we can even call them as plicae circularis. You can even call them as plicae circularis, bache. And they are usually seen in which part of the small intestine? They are mainly seen in the jejunum beta. Yes, in the jejunum of the intestine, we have these valvulae coniventus or the plicae circularis. That's the reason why we have discussed when the jejunal bowel loops get dilated in cases of intestinal obstruction, you are able to see these prominent valvulae coniventus giving us the stepladder pattern. The total number of sphincters at the total number of sphincters which are there beta near the ampulla of Vater. We know at the ampulla of Vater in the second part of duodenum, the main pancreatic duct and the common bile duct, these are the ducts which are going to open up. So at this ampulla of Vater beta, there are actually 4 sphincters which are present. Okay, this was the question. There are actually 4 sphincters which are present, and these sphincters which are there beta, out of them, one is present in the main pancreatic duct, 2 of them are present in the common bile duct, and one is present at the ampulla of Vater. These are together called as the sphincter of Oddi beta. Please remember, these are known as the sphincter of Oddi. If they ask you most alkaline secretion in the GIT is by the most alkaline secretion of the GIT which is there beta, it is by the Brunner's glands of the duodenum. Yes, the Brunner's glands of the duodenum which are there beta, they are going to have the most alkaline secretion. Lymphatic drainage of stomach, if they ask you, occurs in which lymph node? So lymphatic drainage of the stomach occurs in the celiac lymph node. The lymphatic drainage of stomach happens in the celiac lymph node. If they ask you, there are 4 layers in the GIT, we know the innermost is mucosa, then we have the submucosa, then the muscularis and the serosa. So if they ask you which layer is absent in the esophagus, the layer which is absent in the esophagus is the outermost layer known as serosa. Instead of that, we have a very thin layer called as the adventitia beta. So serosa is absent in the esophagus. Submucosa, if they ask you, submucosa is usually absent in a case of gallbladder. Submucosa is absent in gallbladder. If they ask you pacemaker cells of GIT, we know the pacemaker cells of GIT which are there beta, they are called as the interstitial cells of Cajal. The interstitial cells of Cajal which is there beta, these are called as the pacemaker cells of GIT. We know the pacemaker of heart is your SA node or the sinoatrial node, whereas the pacemaker of respiration, which is there, beta, the pacemaker of respiration is known as the, this was also a previous question, pre-Bodzinger complex. It is known as the pre-Bodzinger complex, beta. If they ask you definitely, what is this? This is the femoral sheath, bache. Okay, and this femoral sheath which is there, it encloses three things. Okay, if I go from lateral to medial, the mnemonic is AVN, beta. Yes, why AVN? So lateral most is the femoral artery which passes via it. Then the intermediate one is the femoral vein, and then the medial most one which is there. It is nothing else but the lymph nodes. Okay, in the femoral canal we have the lymph nodes which will pass, the lymph nodes of Clockwood or the lymph nodes of Rosenmuller. As you can see over here, the lateral compartment where there is the femoral artery along with the femoral branch of genitofemoral nerve, but mainly remember the femoral artery. In intermediate compartment is the femoral vein, and in the medial compartment is the lymph nodes of Clockwood or the Rosenmuller, which are the femoral lymph nodes. Okay, so that's important. They give you this normal histological histological picture, and they ask you which organ is this. So we know, beta, there are multiple ducts which are seen over here. Okay, multiple ducts, and along with that, you are able to see a capsule over here. Then that capsule, there are multiple vessels. This is nothing else but the glomerulus. Yes, that capsule which is seen is the Bowman's capsule, bache, and inside that you have the glomerulus, the tough capillaries, and these are all the tubules. So this is the histology of the kidney. Next important, this one organ which is given, beta. Here you are able to see the pinkish cells, and these pinkish cells, they're nothing else but the Hazel's corpuscles. So here you have the medulla. In medulla, we have the Hazel's corpuscles, and then we have the cortex. We have just seen that Hazel's corpuscles, which is there, beta, they are nothing else but the thymus itself. And the last one, which is there over here, you are able to see there is a capsule. Okay, there is a capsule, and then we have the cortex, and then we have the medulla. And inside the capsule, we have the germinal centers as well. This is nothing else but a histological image of a lymph node, beta. This is the histological image of a lymph node. Please remember that. If I talk about the diaphragmatic openings, beta, so please remember the diaphragm which is there, beta, it is a separate, it is the partition between the thoracic cavity and the abdominal cavity. So the thoracic structures, when they want to enter into the abdomen, they are going to enter by the diaphragm at three openings. The openings are respectively at the level of T8, T10, and T12, beta. So the T8 opening is known as the, you can remember the mnemonic voice of America as well. Okay? So the T8 opening is the vena cava opening, T10 opening is the esophageal opening, and T12 opening is the aortic opening. Now, which are the structures passing? T8 or the vena cava opening. Obviously, it will be the inferior vena cava. Along with that, it is the right phrenic nerve, beta. Phrenic nerve is the one which supplies the diaphragm. Root value C3, C4, C5. So it is the right phrenic nerve which is going to pass along with inferior vena cava from the T8. From T10, the esophageal opening. Obviously, it is the esophagus which passes. Then it is the vagus nerve. Along with that, it is that gastric artery. Important, which is there, beta. And the aortic opening, we have the aorta which passes. Along with aorta, beta, we have the azygous vein which passes. Along with azygous vein, we have the thoracic duct, definitely. Okay? So please be aware of that. Next important, if you are able to see, just a minute. Okay. Next important beta over here. This is nothing else but the green covering which is there. Beta, it is nothing else but your carotid sheath. Important is the structures which pass inside the carotid sheath. You have to remember because they ask the exceptions, beta. So we have to remember that the common carotid artery you can see is passing via the carotid sheath. Then the internal carotid artery is passing via the carotid sheath. That's the reason it is called as internal. The branch that goes outside the carotid sheath will be called as the external carotid artery, which supplies the head and neck region. Whereas internal carotid, we know it supplies the brain. Next important bit, the internal jugular vein. Again, why it is called as internal? This is the reason. Because it passes via the carotid sheath. It is known as the internal jugular vein, beta. Next, important, which structures do not pass. One is the external carotid artery, do not pass. The ansas cervicalis do not pass via the carotid sheath. The sympathetic trunk do not pass via the carotid sheath. But the vagus nerve passes via the carotid sheath, bache. Okay, vagus nerve. So it is the vagus nerve, the internal jugular vein, the internal carotid artery, and the common carotid artery, which are the structures which pass via the carotid which pass by the carotid sheath. This we have discussed beta. Whenever we do a lumbar puncture or the spinal anesthesia, the layers which are pierced in sequence is the skin, the subcutaneous tissue, the supraspinous ligament, the interspinous ligament, the ligamentum flavum. Then we have the dura mater, and finally we have the arachnoid mater. The last layer to be pierced in lumbar puncture or in spinal anesthesia is the arachnoid mater. But the last layer to be pierced during epidural anesthesia, when we have to give anesthesia outside the dura mater, it is the ligamentum flavum that we pierce the last bit. Okay? Important is this is nothing as but the HbO2 dissociation curve. In this HbO2 dissociation curve, beta, please remember one thing, that here the graph which is there, beta, if it is shifted to left, if it is shifting towards the negative side of the left shift, this is what is called as the Haldane effect. Okay, this is what is known as the Haldane effect. Beta is easy. Haldane contains L in its name. Okay, so Haldane which is there, definitely Haldane effect is nothing as but the left shift of the graph, whereas definitely beta, it is the right shift which is there. The right shift is known as the Bohr's effect. Okay, R is also there in Bohr beta. Definitely the Bohr's effect is nothing else but the right shift of the graph beta. Okay, important is left shift of the graph. That means the hemoglobin is not able to release the oxygen easily. Here the hemoglobin has more affinity or more love towards the oxygen beta. Here definitely the hemoglobin has less love to the less love towards oxygen. That's the reason it can release the oxygen easily. So the right shift or the Bohr's effect which is there beta, it is due to everything is going to increase except the pH. Only pH decreases. The temperature increases. DPG or the BPG values increases. H plus ion concentration increases. Okay, except the pH. pH is going to decrease. That means acidosis. Okay, that is going to cause right shift of the Bohr's effect. Halden's effect, everything is going to increase over here, beta, except the pH. pH is going to increase over here. That means the temperature decreases. 2,3 DPG value decreases. H plus ion concentration decreases, except pH. pH increases. That is, alkalosis is going to cause the Halden's effect of the left shift beta. Okay, so even in that also you will have L, alkalosis. Acidosis में L नहीं होता. That's how you can remember it easily. Even carbon monoxide and methemoglobin beta both are going to cause left shift to the Halden's effect because they increase the affinity of hemoglobin for the oxygen. That's the reason. Next important beta, these are the various processes these of endocytosis. In the first one, you are ingesting, the cell is ingesting the solid particle. When cell eats a solid particle beta, that is called as phagocytosis. They give you images from physio and they ask you what is this process. So if if the cell ingests a solid particle, that is phagocytosis. Cell eating it is called as. Here, the cell is not ingesting any solid particle but a fluid. That is nothing else but a vesicle is formed. This is called as a pinocytosis, also known as a cell drinking. Okay, this is pinocytosis or cell drinking. And this is a receptor mediated endocytosis beta. And these receptors which are there beta, these are nothing else but the clathrin receptors or the clathrin proteins. So the receptor mediated endocytosis is due to which protein was the question. Answer is clathrin. The classification of the receptors beta, we know there are various kinds of receptors like the cutaneous receptors present on the skin. Then we have the chemoreceptors beta, and then we are having the telereceptors. The telereceptors are the ones for vision, that is your rods and cones. These are the two photoreceptors which are responsible for your vision beta. They are present in the retina. Whereas for hearing, it is the hair cells, the inner hair cells and the outer hair cells in the organ of corti in the cochlea. So definitely the inner and the outer hair cells in the organ of corti of the cochlea beta, they are responsible for hearing. Chemoreceptors can be of two types. One is the taste receptors called as the taste bud or the gustatory receptors. Second are the smell receptors which are present in the upper one third of the nasal epithelium called as the olfactory epithelium. These are the olfactory receptors. Cutaneous or skin receptors are of various types beta. The ones responsible for the touch are the Meissner's corpuscles and the Merker's disc beta. Okay, yeah, the Meissner's corpuscles and the Merker's disc. The ones responsible for the pressure, which is known as the Pacinian corpuscles. The largest receptors are the Pacinian corpuscles, and they're responsible for P for P. Pressure के लिए it is the Pacinian corpuscles. Cold temperature के लिए it is the Croce end bulbs. Okay, Croce end bulbs for cold temperature, and warm temperature के लिए it is the Ruffini end organs. Warm temperature के लिए Ruffini end organs, and pain के लिए बेटा it is the free nerve endings, also known as the nociceptors. Pain के लिए it is the free nerve endings, also known as the nociceptors. Okay, so that was all about your anatomy beta. Thank you so much. Take care. All the best.